Assalamu alaikum. Welcome back. Now we will start our 7th session of the conference and the final one with the title of Unpacking Vital Health Topics from NAFLD to Healthcare Professional Wellness. Our moderators, Dr. Dalal Al-Hajri, Dr. Hanan Al-Fadala, and Dr. Hassa Al-Ansari.
Thank you, Dr. Nasser. Good afternoon, everyone. I have great honor to present our teacher, our mentor, Professor Fuad Al-Ali. He's well known for all of us. Dr. Fuad Al-Ali, he's a board certified in internal medicine and gastroenterology, former professor and dean of faculty of medicine in Kuwait University, member of board of trustees and National Bureau of Accreditation, Ministry of Higher Education, consultant gastroenterologist at Royal Hayat Hospital. Dr. Fuad Al-Ali, thank you too much for being with us today, and the floor is yours.
Thank you so much for this nice presentation. First, I'd like to thank the organizing committee for giving me this opportunity to participate in this wonderful event. I feel truly privileged and honored to be amongst you. So a few months ago, the organizers asked me to give a talk about NAFLD. And it happened that a few days later, the American Association for the Study of Liver Disease decided to change the name from NAFLD to MASLD, Metabolic Syndrome Associated Steatotic Liver Disease. So that stirred a lot of discussion amongst hepatologists, and a lot of people were unhappy. They said, why change the name? Everybody knows what NAFLD is, and you give us this new name. This is very confusing. And that debate reminded me of a famous quote by Shakespeare in the play Romeo and Juliet, when in this act, Juliet was considering changing Romeo's last name because her tribe was at odds with Romeo's tribe. And she felt that if he changed his last name, her family would allow them to get married. And she was telling herself, so what if we change the name? Nothing will happen. It's the same. A rose will still smell good even if we change the name to another thing other than rose. But I really, in case of NAFLD, I don't agree with this quotation. I think the ASLD had some good reasons for changing the name. And so to convince you of the merits of the name, let's look at these 4 scenarios. These are 4 patients who don't drink alcohol. All of them have biopsy-proven fatty liver. So the definition of fatty liver is fatty infiltration of more than 5% of the hepatocytes. So we have this 45-year-old man who's HIV positive with raised LFTs and fatty liver. He doesn't drink alcohol. So literally speaking, he has NAFLD, non-alcohol fatty liver. The second patient is a 15-year-old girl with Wilson's disease. So Wilson's disease is one of the causes of fatty liver, and it's not alcoholic. So it is NAFLD. The fourth patient, D, is a 67-year-old with heart failure, atrial fibrillation on amiodarone. And amiodarone is one of the causes of fatty liver, and not related to alcohol. Now, if we use the definition if we use the term NAFLD, literally all of these people have NAFLD, but only C, a 60-year-old with diabetes and hypertension and raised LFTs, genuinely has NAFLD, which we talk about in our clinic. So I think the change of name was meritorious. So this is a more comprehensive list of causes of fatty liver. Of course, one major one is alcohol, but all the rest are non-alcoholic fatty liver in a way, literally speaking. But as you see, it's a very heterogeneous list of causes. Heterogeneous in terms of pathophysiology, in terms of clinical presentation, in terms of prognosis. For example, acute fatty liver of pregnancy is almost universally fatal if you don't deliver the baby as quickly as possible. Rye syndrome is same way, and they have different pathophysiological mechanism. Wilson's disease, totally different pathophysiological mechanism. Now, these three, type 2 diabetes, central obesity, and dyslipidemia, share the same pathophysiology, the same presentation, the same histopathology, the same treatment. And probably it is this type of liver disease, this type of fatty liver disease that should be put together and given its own name. And that's the justification for it. Now, there is another reason, a more curious reason, and that is MASLD, metabolic syndrome-associated fatty steatotic liver disease, is a better name politically. How politically? So you have this old man that comes to your clinic, he just finished Salat al-Dhuhr, قلت له حجي عندك دهن في الكبد بس مو من المشروب. That doesn't sound very nice. He will definitely be offended. Similarly, a young, self-conscious lady, you tell her, oh, you have fatty liver. Fatty, fatty has some negative connotations. So both for political reasons and for scientific reasons, NAFLD is no longer being used, and we use the word MASLD. So what's the definition of MASLD? It's fatty infiltration of more than 5% of the hepatocytes, with or without inflammation or fibrosis, in the absence of other causes of fatty liver disease. So it's to an extent a diagnosis of exclusion. And the common pathophysiological mechanism is insulin resistance and the metabolic syndrome. And of course, another criteria for making a diagnosis of MASLD is absence of alcohol abuse, excessive alcohol use. So for men, drinking more than 21 drinks per week, and for women, drinking more than 14 drinks per week excludes the diagnosis of MASLD. Just briefly about the pathophysiology, several factors play a role in the pathogenesis of MASLD. So the main, of course, factor is environmental, excessive energy intake, which leads to obesity. Obesity leads to secondary insulin resistance. The gut microbiome may play a role. Some people believe that many of these patients have abnormal bacteria in their colon that generates abnormal bile salts that are toxic to the liver. And of course, genes. So we have several families in Kuwait that have clustering of this progressive form of fatty liver disease. So you see the father and the son, or 2-3 brothers and sisters, all on the list of transplantation because they have cirrhosis due to fatty liver disease. So not everyone who is overweight or obese will develop cirrhosis and progress to liver failure. This slide is a reminder about the term, the classification of fibrosis, because we're going to use this classification in more than one slide. So just to remind you, fibrosis, hepatic fibrosis, is classified into 5 stages. F0, which means that there is no fibrosis, just fat. F1 is portal fibrosis, which is very mild, is considered mild. Periportal fibrosis is F2. Bridging fibrosis is F3, and cirrhosis is F4. So F0 and F1 are lumped together and considered almost like normal. Most people are either F0 or F1. F2 is moderate fibrosis. F3 and 4 are advanced fibrosis. So what's the spectrum of liver disease in MASLD? So just like alcohol, we used to say alcoholic fatty liver, alcoholic hepatitis, and alcoholic cirrhosis. It's similar. So we have simple steatosis, metabolic syndrome associated steatosis, no inflammation, no scarring. Then we have steatosis, steatohepatitis, which means fat and inflammation, and the inflammatory cells are usually neutrophils, and steatohepatitis has a worse prognosis. It can progress to cirrhosis in 30% of patients. And the best predictor, we have hundreds and millions of people with fatty liver, and that's a challenge. Who is likely to progress? Whom should we pay attention to? Because you cannot really be very aggressive with millions and millions of people. So the main challenge for you as a primary care provider is to identify those who are at risk and refer them to the hepatologist. Otherwise, it will be logistically impossible to refer all the patients with fatty liver to the gastroenterologist. So people with simple steatosis, no inflammation, have excellent prognosis. They rarely, if ever, develop cirrhosis, but those with inflammation, they do. But the best predictor is having F2 fibrosis, periportal fibrosis. That's the best predictor that this patient is going to develop cirrhosis. So this is a question about the epidemiology of fatty liver. So what is the prevalence of MASLD in developed countries, and in a country like Kuwait or Gulf countries where obesity and type 2 diabetes are rampant? And the answer is, it is 20 to 40% approximately. So it's very common. If you want to remember a single number, it's 25%. So 1/4 of the population have MASLD. This is another question, because the patients, when they come to you and you tell them you have fatty liver, they will say how dangerous it is. What are my chances of developing cirrhosis? So these are good numbers to remember, to quote when you're sitting with the patient in the clinic. So 8 to 10% of all of MASLD patients will develop cirrhosis. If you take MASH, those with steatohepatitis, 30% will develop cirrhosis. Whereas those who have only simple steatosis, less than 5% will develop cirrhosis. So all of the above statements are correct statements about the natural history of MASLD. This is another slide which reiterates what I have just said. So 20 to 40% of the populations in developed countries have MASLD, and the prevalence is even particularly high in type 2 diabetes. So a lot of type 2 diabetes have MASLD. Now, a nice examination question that the boards like is, what is the commonest cause of death in people with MASLD? So the knee-jerk response is cirrhosis, but that's wrong. The number one cause of death in people with MASLD is coronary artery disease. And the number two cause is non-liver cancer. Obesity makes people susceptible to cancer. So the number two cause, liver disease is number 3. So most of these people die from heart disease before they develop liver failure. That's why you don't see a lot. So many people, 25% of the population have fatty liver, and 10% will develop cirrhosis. Where are these people? They die before they come with clinical liver failure. What is the rate of progression? So the patient comes to you and they have F2 fibrosis. They say, how long am I going to live? And even if they don't ask, you should tell them, actually, that for every stage, it takes about 7 years. So if you are F2, you're going to become F4 within 14 years. That's the average. Although there are some exceptions. Some people have a more rapid progression. So 7 years per stage, so it's a slow disease. It's a slow disease. Let's look at this clinical vignette, which is classical for patient with MASLD. 58-year-old man, type 2 diabetes, dyslipidemia, and hypertension. Typical patient. He's on metformin, rosuvastatin, and valsartan. No alcohol consumption. His father died of liver disease. Most of our patients, I don't know, بس والدي توفى من 20 سنة قالوا الكبد خربان يعني بس they don't know, but could be still also fatty liver disease. In fact, in the old days when I was a medical student, we used to call it cryptogenic, but it turns out that many of these cryptogenic diseases were really fatty liver disease. As they develop cirrhosis, the fat decreases in the liver. So when we do a liver biopsy on a cirrhotic, even if it was due to NAFLD or MASLD, I have to change my habit now. Even if it was due to MASLD, still you may not see a lot of fat. So you miss the diagnosis and you label them cryptogenic. So he is obese. The left lobe is enlarged. That's a very important overlooked physical finding. If you find a left lobe that is palpable and the right lobe is not palpable, this patient is cirrhotic. You don't need to even do a liver biopsy. It's a very useful physical finding. If you look at the labs, routine labs, you can also make some guesses. A platelet count of 130,000 is not normal. In fact, 140,000 is not normal. In fact, maybe 150 is about to be normal. So if you see a platelet count of 150 or less, you have to worry. An AST, which is higher than ALT, also worrisome thing. Some patients have high ferritin as well, which is a secondary phenomenon and should not really trigger investigation for genetic hemochromatosis. This is not genetic hemochromatosis. This is secondary to the MASLD. So which of the following indicates that the patient has advanced liver disease? We answer this question. So an AST higher than ALT is not a good sign, and the platelet count below 150. So both of them, as you are sitting in the clinic, can predict that this patient has significant fibrosis. Which of the following medications should be stopped? So a common error done by, I see it in a lot of patients, that their primary care doctor or the internist, once they see slightly raised LFTs, they immediately stop the statin. And that is not the right approach. Statins, in my 40-year career, I've seen only one patient who had raised LFTs due to statins. So statins are extremely safe. In fact, there is some tangential data to say that statins are good for the liver. So don't stop the statins. Metformin and valsartan are also fine. You should not stop them. How to diagnose MASLD? So history, physical exam, labs. History, of course, most patients don't have symptoms until they have liver failure. But your history should be focused on identifying risk factors that makes them susceptible to develop cirrhosis. So type 2 diabetes is a risk factor. Of course, morbid obesity, dyslipidemia, and other features of the metabolic syndrome. And also having a first-degree relative. So if the patient has fatty liver and they have first-degree relative who develops cirrhosis or liver failure, then the brother or sister are at high risk of going through the same course of aggressive fatty liver. Of course, as we said, it's a diagnosis of exclusion. So if they have abnormal LFTs, you have to rule out other causes of abnormal LFTs, such as medications, IV drug use for hepatitis B and C. And of course, you have to take a good history about alcohol consumption. But most of our patients are usually referred because their LFTs are abnormal, or because the ultrasound accidentally found fatty liver, or sometimes the surgeons refer the patient because they do laparoscopy for whatever reason and they find a cirrhotic liver or a fatty liver. But this is the whole idea behind this lecture, is that you guys should start screening your patients who are at risk for liver disease due to mast cell. You should screen them according to certain parameters which we're going to talk about. Physical examination or BMI of more than 30, bad sign. Jaundice. Jaundice is not a presentation of mast cell. So if you have a patient who comes to you, I'm jaundice, and you do ultrasound and they have fatty liver, that's not the cause. There's something else. Usually, cirrhosis due to fatty liver usually manifests the other features of liver failure, like ascites, portal hypertension, variceal hemorrhage, before they become jaundice. So jaundice is a very late feature of cirrhosis due to mast cell. Splenomegaly is another sign of advanced liver disease, AST more than ALT, low serum albumin. The other thing in interpreting LFTs in these patients, that if you see ALT and AST of more than 300, this is very unlikely to be due to fatty liver. There is something else. So mast cell doesn't cause very high transaminases. We said that it's a diagnosis of exclusion, but you don't really have to do a full panel of investigations to rule out other causes. Generally, the minimum is to do hepatitis A, B, and C serologies because they have abnormal LFTs. Other investigations for autoimmune, Wilson's disease, etc., are only done if it is indicated. You know, if there is a hint. If there is no hint and the patient is typical, only hepatitis A, B, and C are warranted. And beware of the ferritin. It may be slightly elevated in these patients. It doesn't warrant screening for genetic hemochromatosis. In fact, genetic hemochromatosis doesn't exist in Arabs. Let me give it to you. You know, I stopped ordering it as an investigation for chronic liver disease. So the best predictor of prognosis, of progression of mast cell is F2. So your job is, number one, to screen your high-risk patients, and we're going to say who are the high-risk patients, for F2. For F2, because if you find F2, you have to refer them to the gastroenterologist or the hepatologist. And we have 4 non-invasive strategies. One is called the fibrosis 4 score, FIB4 score. The other one is called enhanced liver fibrosis score. And then we have a machine which is similar to the ultrasound called shear wave elastography. And then we have the MRI. So how do these techniques compare? So the easiest and the cheapest and the most readily available is the FIB4 score, which you can calculate using an app on your phone. It is derived from 4 parameters: age, ALT, AST, and platelet count. And a score of less than 1.3 should put you at ease that the patient does not have significant fibrosis. You can manage him. You don't have to refer him. A higher number warrants fibroscan and further evaluation by a hepatologist. ELF is also derived on serum parameters, but these are not readily available tests. They are sent abroad. They are expensive. I don't find any advantage in using them. Fibroscan is a wonderful tool, non-invasive tool, available in all government hospitals in the GI unit. It's not in the radiology department. And it is available also in the private sector, and it is more reliable than the FIB4. But we cannot send all the patients for fibroscan. We only send people with a high FIB4 of more than 1.3. Then MR elastography is more accurate than fibroscan, but it is expensive, it is time-consuming. I don't think, maybe only the SMAN Diabetes Center have the software. I don't think the other hospitals have it, and they do it for research purposes. So in practice, in your clinic, do the FIB4. If the patient has a problem, refer them to the gastroenterologist to do a fibroscan. If they confirm a high FIB4, they'll keep him for follow-up. But if it doesn't confirm, they will refer him back to you. Liver biopsy is the gold standard, but it is invasive, it's expensive, it has risk, and needs special expertise. So we only do it when there is an overlap. So the patient has fatty liver, but maybe the antinuclear antibody is positive. We don't know. This is autoimmune, not autoimmune. So we do it when the case is not very clear. Who takes care of these people? Actually, the bulk of the work is done by you guys, because their treatment is weight loss, controlling their risk for coronary artery disease, control of their diabetes. There is no medication for us. Now, we get into the picture to identify cirrhosis and treat its complication, look for varices, screen for hepatocellular carcinoma, etc. Of course, the dietitian plays a huge role, the diabetologist, and sometimes we need the bariatric surgeon. So who is at risk? Who do you want to check them for FIB4? So any type 2 diabetes should be screened for FIB4, any type 2 diabetes, because the chances of having MASLD is 60%. Any patient with two features of the metabolic syndrome, Any patient with raised liver enzymes, and the normal liver enzymes are ALT or AST of more than 30. It's not like 50 or 60 like sometimes is quoted in some panels. So these patients should be screened, and to identify them. And your role is not only the liver, but more importantly, modifying the cardiac risk, because this is the main killer. It's not the liver, the main killer is cardiac risk. Simply, I tell my patients, I want to see you after 6 months, and I want you to have lost 10% of your weight. So if you weigh 80, I want to see you're weighing 72. And I want to see a hemoglobin A1C, which is 7 or whatever, a good for age, and a reasonable hemoglobin A1C, a good blood pressure, and a normal lipid profile. Does it work? So if you lose 10% of your weight or 5% of your weight, what happens? Yeah, it works. So even fibrosis can regress, especially F2, F3, it can regress. F4, difficult to regress. But if you catch a patient, he is F2 or she is F2 or F3, yeah, it regresses if they lose 10% of their weight. So weight reduction is very effective. But who loses weight? No one loses weight. And even if you lose weight, you're going to catch it back, or the weight will catch you. So surgery. So although I hate surgery, it's not a panacea, a lot of problems with surgery, but bariatric surgery also really works in terms of the fat, in terms of the inflammation, and in terms of the fibrosis. It really regresses dramatically. For those who fail conservative therapy, I reluctantly tell them, "Khalas, we tried now for 2-3 years, you're not getting better, just go and do the surgery." But there is a step before that. So this is the recommendation of the American Society for Endocrinologists. So basically, we tell people to lose weight, 5 to 10%. We tell them to exercise. So I tell my patients, do 30 minutes to 1 hour of dynamic exercise, of aerobic exercise, and 20 to 30 minutes of resistance exercise 2 times a week. Consume food, consume energies in such a way that you are creating 500 calorie deficit. So if you create this, you will lose weight. And if that doesn't work, please consider GLP-1 agonist or terzepatine as well. It has these 2 medications, especially semaglutide and terzepatine, have been shown to reduce fat in the liver dramatically. They have not been shown to reduce fibrosis, probably because the studies followed patients for a short period of time. So if the patient fails diet and exercise, please consider these 2 classes of medications. If they don't work, then you have surgery. There is no FDA-approved medication for the treatment of MASLD, unfortunately. So that's why the bulk of the treatment is in your hand and in the hand of the diabetologist. So this is a summary. Risk factors, identify these people, screen them with FIB4, If they have a FIB-4 of more than 1.3, send them for fibroscan, and then according to the result of the fibroscan, to retain them with the gastroenterologist, or just they come back to you. And you need a minimum of hepatitis B surface antigen and anti-HCV for these patients. All of them should have one, and other investigations if needed. This is, of course, a very complicated slide. It just shows you that there are at least 30 medications being under investigation to treat MASLD. And hopefully, one or more will be available within 3 years. So in summary, ladies and gentlemen, MASLD is a common condition. It's associated with a lot of morbidity, cardiovascular and hepatological morbidity. You should screen your patients who are at high risk, particularly diabetic patients or those who have 2 risk factors for the metabolic syndrome. Screen them, use the F4, refer them if they have high F4, and weight reduction, GLP-1, tirzepatide are all to be considered. And remember always that the surgery, keep surgery till the end, but don't send them when they are already cirrhotic. Try to send them relatively early when things are reversible. Thank you very much.
Thank you, Dr. Fouad, for this excellent presentation. If you don't mind, we have some questions for you. طبعاً plenty of questions. I will choose some for the sake of time. Does the ketogenic diet cause MASLD?
Severe malnutrition can cause, but no, ketogenic diet, the way as supervised by a dietitian, shouldn't cause MASLD, because it's a diet, it's not meant to cause malnutrition. So we don't care about what diet the patient should use. Ketogenic, balanced diet, low carb, as long as they have 500 calorie deficit a day. So they can calculate their basic metabolic rate, add the calories that they lose with exercise, and they should eat 500 calories less. Whichever diet is fine.
Thank you. When shall we stop using statins for MASLD patient? And is there any preference in using rosuvastatin upon other anti-lipid medication in MASLD patients?
Not really. I think all statins are fine. I mean, some people talk about pravastatin being safer for the liver. But as I told you, we, as hepatologists, years ago, have been trying very hard to convince the internists and the primary care providers and the diabetologists that statins are not harmful for the liver. In fact, if you see an AST going up, it's probably from the muscle. Do a CPK, because most probably it is muscle origin, not the liver. Very rare. I have seen only one lady who consistently, every time we returned her to the statin, the LFTs will go up. But it's extremely rare. So you can choose anything as indicated without, and I see a lot of patients being, switched to Repatha, which is much more expensive, and I don't see any reason. They have just MASLD and their LFTs are high because of the fatty liver, and it will go down by dieting and weight reduction, not by stopping the statins. So there's no need to rush and quit the statins, regardless of which kind. I don't recommend any specific type.
Is there any role for over-the-counter medication like vitamin E or antioxidants pills in MASLD patients?
So the AASLD guidelines cautiously recommends vitamin E for non-diabetics with biopsy-proven steatohepatitis. Biopsy-proven, non-diabetic. So there are a lot of conditions. So you have to do a liver biopsy, and your biopsy should show steatohepatitis, means fat plus inflammation, and you should not be diabetic. They may say, okay, use vitamin E. So a lot of conditions. Vitamin E, as you know, is not a very safe vitamin. So the risk of malignancy and mortality from prostate cancer and all this is raised in vitamin E. So I don't tell my patients. Besides, it gives a false sense of security. You know, like, for example, I take statin and I'm going to have a steak now because I'm taking statin. I don't need to worry about the steak. But that doesn't apply to vitamin E. The data is not that clear about it. So you may say, oh, I'm going to do whatever. I'm not going to lose weight because I'm taking vitamin E. That protects my liver. So no, I don't recommend. There are other also herbal medications, milk thistle and other stuff in the market. I don't recommend them. The evidence is not there.
Some asking about apple cider vinegar.
Yeah.
Any role for it?
No. No evidence.
Thank you so much,
Thank you.
Professor Fuad. Now, Dr. Dalia Saleh, on behalf of the head of the conference, Dr. Dira Dweib, will give a certificate of appreciation for our Professor Fuad Al-Ali. I have just one comment, just to for your next, يعني إن شاء الله في primary care. Now we are trying to integrate the FIB4 score in our system for screening, and we started with an initiative from Amiri Hospital. One of the Dr. Munira Tarrah, she's a gastroenterologist and hepatologist. She explained for us how we refer and when to refer our patient after screening with the FIB4 screening tool. If the result is less than 1.3, there is a new established muscled clinic in Amiri Hospital for only the capital district, to which we can refer our patient for further screening if the FIB4 is more than 1.3. Just for you to know, and later on we will expand this to cover all the health areas.
So please welcome our second speaker, Dr. Marwan Al-Qina'i. He is an otolaryngologist practicing in Kuwait. He has a special interest in rhinology and skull-based medical education and research. The floor is yours, Dr. Marwan.
Thank you, Dr. Hassa, Dr. Dalal. Thank you, everyone, for coming. Last day, you've all made it to the end. So ENT problems in pediatrics, okay, diagnosis and management. I think ENT in a primary healthcare setting needs more than one lecture, and I've said this to Yusuf and the organizing committee many times. It's a very important aspect of the primary healthcare. So 25 to 40% of all GP consultations are ENT related, and these numbers are from UK studies based. It has a broad spectrum of practice. It's a continuously expanding and evolving specialty. And what I mean by that, like we're creeping into other specialties. Now we do more head and neck, we do thyroid, salivary glands. We're doing more into the these small pediatrics patients. We go to the geriatric cares, and it's also evolving. We're doing more transoral robotic surgery right now. There are also a lot of evolvement into the fields of cochlear implantations. So ENT in general, it's an expanding and evolving. It compromises of a lot of the primary healthcare consultations. And just a general overview about our specialty, and it's important to know that, to know what's the scope of ENT practice for a referral point of view. We have different subspecialties. We have the rhinology and skull base, and that's what my interest is mainly in. We do sinus, nasal work, facial plastics, rhinoplasties, more and more are doing facelifts and blepharoplasties. We have a huge head and neck practice in Kuwait. These are ablative and reconstructive elements. We do a lot of pediatric airways. And what I mean by pediatrics, not only the adenotonsillar disease, but also the airway reconstructive congenital deformities, And otology and neuro-otology is also another subspecialty, all to do with the ears, the lateral skull base aspects, and finally laryngology. In laryngology, we look at aspects of the voice disorders, vocal fold polyps, cysts, and other neurological diseases that can affect the vocal folds or vocal cords. Now, this is a general overview about our specialty in general. So today I'm going to focus on a common ENT problems. I'm going to start with a very important topic, the adenotonsillar disease. Then the discharging ear and how to deal with that. And I'm going to touch, of course, on non-discharging ears and the otalgia patients. Epistaxis, another important point. The blocked nose patient and how to deal with it. And finally, if I have time, foreign bodies. Now, fitting all of these in 30 minutes is a challenge, but we're going to do it together. It's very important, and we're going to go through it quickly. I'm going to focus on very high-yield topics and very high-yield points within these topics, not to bore anyone, okay? So, tonsils. I have this image here. When we have tonsils, the part of the wild ears ring, we can see how the airway is significantly compromised by hypertrophied tonsils. After tonsillectomy, it widens and the area improves. The airway improves, the patient stops snoring, and the sleep disordered breathing that the child is complaining in improves. So general tonsils are part of the wild ears ring of tubal pharyngeal tonsils, which we call the adenoids. Tubal tonsils, what commonly known as tonsils, what we call around the eustachian tube, and palatine tonsils is what we commonly call as tonsils, and then we have lingual tonsils. It's the tongue base. Why it's important to know this image? Medically speaking, tonsils mean none of these, but commonly speaking, when we talk about tonsils, we mean the palatine tonsils, and the adenoid is called the pharyngeal tonsil. Now, all of these form the wild ears ring. These are a group of lymphoid tissues that provide immunity, and it's considered to be the first level of immunity in the oronasal cavity. So, tonsillitis. Now, when you have a patient with tonsillitis, the typical symptoms of sore throat, enlargement of the tonsils, they have the exudates on the tonsils, difficulty in swallowing patients, pyrexia, you might be febrile, and feeling generalized weakness. They can have a bad breath, and this can take long to recover after treatment, and also referred pain as earache. It's very important to differentiate between referred pain due to tonsillitis and otitis media or acute otitis media. Now, the most common organisms is group A beta streptococcus, Marxella, and H. influenza when we're talking about bacteria. And the next slide, we're going to know how to differentiate between bacterial infection and a viral infection, if it's possible to differentiate in a clinical setting. Okay? Now, there are different phases of tonsillitis. When you get a child with sore throat or even just fever and you don't know where the fever is from, you check the throat, you check the ears. You want to see the common causes of a fever that the child is presenting with. Tonsillitis can have different phases. You do not have to see the pus on the tonsils to know that this is a tonsillitis. It can be in the tonsillar erythema. Then it goes into the exudative tonsillitis, which we commonly present or see children in. Follicular tonsillitis, when you have a yellow spots. Okay, the exudative when you have purulence. And then cryptic tonsillitis. Now, I just want to talk about cryptic tonsillitis. Now, naturally, all tonsils have crypts, and that's part of the technique or the method or the pathophysiology of providing immunity, that the microbes, the foreign material is stuck in these crypts, allows times for integration of the immune system to provide antibodies. In chronic infection or recurrent infections, those crypts become more prominent and chronically inflamed. And when you have a cryptic tonsillitis, it's a chronic infection. It's not the recurrent acute or the normal acute tonsillitis. Now, antibiotic use, I'm going to touch on guidelines. It's mostly based on penicillins. If allergic, we go to macrolides. Provide bed rest, hydration, analgesia in all cases, and oral hygiene. There are different sprays that can be used. What's the evidence for and against are not that strong, to be honest, with regard to the oral sprays. However, it is given to provide some relief. Now, is it viral or bacterial? The never-ending question. We use clinical scoring tools in clinic. And these scoring tools help us to differentiate whether it's a viral or a bacterial infection. So we have two main clinical scoring tools, the fever pain and Centaur. These are based on studies performed on thousands of patients. The Centaur criteria, although commonly used, it's only the studies that were done to give us the Centaur criteria were done in adults only, okay? The fever pain were done in the pediatric population, but not under 3 years of age. But we apply it using clinical knowledge. Okay, so fever pain, it's in the last 5 years more commonly used than the Centaur. It's when you have a fever during the last 24 hours. Purulence, you see purulence. It's tend rapidly, or within the fever comes 3 days after the onset of symptoms. Severely inflamed tonsils, and absence of cough, or no cough or coryza. Now look at the scoring and the percentage here. Now these are the scores depending on this criteria, and these are the percentage or the chances of it being a bacterial infection. Okay, so 0 to 1, it's not 0% chance of having a bacterial infection. It's actually 13 to 80%. What I'm trying, or the message I'm trying to deliver here, that if a patient does have a low fever pain or a Centaur criteria, it does not mean he does not have a bacterial infection. So what do? I can't give up. I give antibiotics to all patients, you know. We have the infection control on us, resistance, bacterial resistance. You have two options, okay? You either give a patient a lifeline or information that if the condition does not improve, if the fever stays with you, please come back. Or step 2, you can give a backup prescription. It's a commonly also done practice, especially in a very busy primary healthcare setting. Okay, so as you see here, if you have the score of 0 to 1, you have 13 to 18% of being bacterial. 2 to 3, it's 34 to 40, and when you have 4 to 5, it's a high chance, 62 to 65. So it's never 0, never 100%. It's all to do with this clinical knowledge and history taking and your sense as a doctor, and you give the patients the information needed for them to come back whenever the symptoms do not improve or fever or get worse or the fever persists. So the Centaur criteria, I think everyone knows it here, is the tonsillar exudate, tender anterior cervical lymphadenopathy, a history of fever, it has to be over 38 in the Centaur criteria, and the absence of cough. So 0, 1, or 2, there is a 3 to 17% chance of having a bacterial tonsillitis or strep A, and 3 to 4, it's 25 to 50%, 56%. Now, why am I insisting on giving antibiotics to the bacterial tonsillitis patient? Because we do see complications, okay? And complications of tonsillitis can be divided into suppurative and non-suppurative, okay? So suppurative complications, cervical lymphadenitis. So when you have a suppurative lymphadenitis of the cervical lymph nodes, you have peritonsillar abscess, commonly known as quinsy, and deep neck space infections. Now, a deep neck space infection is a whole chapter in the head and neck curriculum. We have potential spaces in the neck that infection can travel through. And when they travel to and create separation, they might need further surgical intervention to relieve this. And you have non-suppurative medical complications that could happen, such as rheumatic fever, post-streptococcal glomerulonephritis, PANDAS. We all know what PANDAS is, I think. Yes, okay. Laryngotracheal bronchitis, bacterial tracheitis, and supraglottitis or epiglottitis. And you know these are emergency conditions that require urgent attention. So we do see complications. If not in a primary healthcare setting, in a hospital settings, it's not uncommon to see delayed treatment of tonsillitis that gives us these complications. I think parents trust primary healthcare doctors more than general doctors, okay, or specialized doctors. Tonsillectomy indications. When do we do tonsillectomy? And this is a question that you will be having faced. So there are absolute indications and there are relative indications. So there are conditions that we have to remove the tonsils. We have suspected malignancy, okay, children with obstructive sleep apnea, and it's part of another procedure done, such as access to the parapharyngeal space, and in hemorrhagic tonsil, very rare, I've seen 2 in my short career. And relative indications for surgery, it's the Paradise criteria, 7 in 1 year, 7 infections in 1 year, 5 in 2, 3 in 3, for consecutive years, and if we have more than 1 quinsy episodes. Now, these are all based on guidelines, on a lot of research done, but is it always a rule that we have to follow? There are other options or other factors that play a role in when to do a tonsillectomy, and it's tailor-made to each patient, and each patient is considered separately. Now, there are things to consider. Any other condition, comorbidities, any allergies to medications. There are some patients that cannot tolerate any antibiotics, okay? And in these patients, we cannot allow a lot of infections and to deal with the complications, you know? So there are a lot of things that need to be taken into account before making such a decision. And as I always say, it's good to know what the guidelines say, but then there are other things that the specialists have to decide. And for those of you interested, I think you all like to read more. Clinical Practice Guidelines for Tonsillectomy in Children. It's a very nice publication of the American Academy of Otorhinolaryngology. So, another question. Doctor, if I remove the tonsils, will it lower my child's immunity? As tonsils are lymphoepithelial organs, so what happens that with recurrent infections, the tonsils itself lose its ability to provide immunity. And there is no control of the influx of antigens. So it's chronically inflamed and does not provide immunity. So the existing tonsils are not doing its job. Although research showed that after tonsillectomy there is a reduction in the Ig levels, but this reduction does not correlate to clinical. So statistical significance does not always correlate to clinical significance. It's very important when we're analyzing papers and guidelines, because this, I think, made the BBC news or CNN news, I think, this paper that was published. And in the news, they say that the tonsillectomy does lower the immunity, and we had a huge refusal to do tonsils, and still do. But sometimes it is necessary to be performed, or we'll have a lot of complications. So this is a very common question, and all doctors need to know how to answer it in a correct way. This question, doctor, will tonsillectomy lower my child's immunity? Now, going to the adenoids, or also known as pharyngeal tonsils. They're at the back of the nasopharynx. Now, that's an endoscopic image of the, maybe. Okay, that's an endoscopic image of the adenoid tissue in the nasopharynx, and that's the eustachian tube. Now, the eustachian tube is the attachment of the route of access to the middle ear. Laser. Okay, so that's the adenoid tissue at the back of the nose. That's an endoscopic image through the nose, and that's the eustachian tube orifice. Imagine it here. And when we have a large adenoid, it can block the exit of the fluids from the middle ear into the eustachian tube, or provide a colony for bacteria for ascending otitis media infection. So adenoid tissue on nasal camera exam, and that's the back of the throat, does provide obstruction. And it's not about it does also affect the breathing from the nose. And we do have a condition called adenoiditis. You know, it's not also the tonsillitis can get infection. Also the pharyngeal tonsil can get infection. Get a sore throat, purulent rhinorrhea, دكتور ولدي خشمه يصبصب على طول. That's a very common complaint. Halitosis, postnasal drip, coughing until vomiting. We see it a lot, especially this period. Nasal obstruction, fever, and association with concurrent otitis media for the reasons I say. And just to make it, just to elaborate more, the eustachian tube in children is different than those in adults. It's flat, it's more soft, it gets blocked easily. So this horizontal orientation, more than the vertical orientation here, means that fluids can easily be refluxed into the middle ear. It means can get obstructed easily. That's why children get more recurrent otitis media and otitis media. So there is an anatomical variation between adults and the children or the infants eustachian tube. Okay, I have to speed up now. So before we leave this topic, okay, I just want to introduce the concept of sleep disordered breathing. Okay, it's a set of ventilatory disorders ranging from snoring to obstructive sleep apnea. Now, documented that OSA does have some prolonged complications, okay? So they have learning difficulties, emotional dysregulations, behavioral concerns, cardiovascular and metabolic complications. And what are the contributing factors to have OSA? It's enlarged adenoid and tonsils, craniofacial abnormalities, obesity. Prof. Fuad touched on that. At Kuwait, we have a high rate of obesity, and we see a lot of OSA due to that. Abnormal muscular tone of the upper airway and abnormal drive to breathe. These are the contributing factors. Now, we do have reversal of these symptoms after providing the adequate treatments like adenotonsillectomy, and we do see it in pediatric population. All right, so that's a brief overview about adenotonsillar disease, and I think it's a very important topic that should be touched upon, and I'm happy to answer any questions. Now back to another important topic, the discharging ear. When you get a child in clinic, you examine the ears and you see this. You do not have a scope. You do not have a suction device, okay? And you see just purulence from the ear. Doctor, the child is coming with discharging ear, and sometimes it's foul smell. But when you do, you have a suction and a scope, that's what will you see. So that's a case of acute otitis media. I'm going to talk about the stages in the suppurative phase. So what happened is the pus bulged through the tympanic membrane into a perforation in the middle here. Okay, it's very clear. Now I'm suctioning into the middle ear. Now that's the tympanic membrane. I'm suctioning into the middle ear. And you can see that inflamed red tympanic membrane. And that's what I'm trying, or the message I'm trying to convey is that what you're going to see if you do all the suction in the clinic. So this is like an acute otitis media suppurative phase. Okay, so when you have a discharging ear, ask, is it painful or not painful? When there is no pain, okay, you examine the tympanic membrane, and the tympanic membrane has a perforation. It's it's a chronic otitis media, okay. And if there is no, if there is a perforation, and it's a posterior superior, marginal, there is a small growth, granulation tissue. Always be suspicious for cholecystoma, and that's if it's painless. If it's painful, just ask. Is it discharging or not discharging? And if the pain came before or after the discharge. If before, and you see a bulging TM with a normal external auditory canal, EAC is external auditory canal. Okay, the canal itself, it's most likely acute otitis media. If you see a narrow external auditory canal, there is, you cannot visualize, there is tender on palpation of the external ear. Always think of otitis externa, which is not uncommon to be seen. Okay, now acute otitis media. So the definition, or how the diagnosis is moderate to severe bulging of the tympanic membrane. It's new onset otorrhea, not caused by otitis externa, so the canal is normal. And when you have a mild bulging of the tympanic membrane, but you have otalgia or erythema of the TM. And as I said, there are different stages. It starts with hyperemia, when you have the eustachian tube block, extudation, suppuration, when we see, like we saw in the video, okay, and coalescence. And at each stage, if you give the proper antibiotics or management for this patient, at each stage, we can revert into the healing stage, and that's what we aim for in TM, okay? I have less than 10 minutes. I think we have time. So again, the ultimate question, when do we give antibiotics for management? Now, for the management of acute otitis media. Now, first of all, we have to start, when it comes to management, analgesia to all patients. Now, all patients with acute otitis media have to start with analgesia. And there are a lot of controversy between different bodies, like we have the American Academy of Pediatrics, the American Academy of Otolaryngologists, and the British General Practitioner Society. They all gave guidelines. And children 6 months of older, and these are done on studies, or the recommendations done for patients 6 months or older, okay? If there is otorrhea, okay, or severe signs and symptoms like moderate to severe otalgia for at least 48 hours, and more than 39% degrees Celsius fever, we give antibiotic therapies for 10 days, okay? When it comes to children, 6 to 23 or 2 years, okay, we do give antibiotic therapy if it has bilateral. In unilateral, we do give if the symptoms are severe. But then they say in the guidelines, then we can observe, okay? So it is controversial even within the authors themselves. So it's all to do with, to the bottom line, it's all to do with the symptoms of the patient, okay? I have less threshold in giving antibiotics for acute otitis media, especially if the patient is young, from 6 months to 23 years old, and they have severe symptoms of otalgia, unable to sleep. Okay. Now, 2 years of or older, okay, the duration is less than 2 years. So here it's 5 to 7 days, but in less than 2 years, we do it for 10 days. That's another important point. The first line, or the recommended first line, is amoxicillin, but in augmentin, I prefer augmentin, or also the guidelines recommended that we do have give augmentin. The problem in Kuwait, we do not have a study focused on our own microbial stewardship or microbial data. So we do go with the amoxicillin with clavulanate. The dose differs, you all know that, it's 90 milligram per kilogram, and this is best provided in the ES or the extended release, as the dosage of the clavulanate will become less when we give it. Okay, we have alternatives, second line generation, cephalosporins and rocephin if it's severe, IM not responding. Anyways, you can all read that later. I just have to speed up for time. It's very important to note. Children with middle ear effusion and anatomical damage, you examine, you do not see the tympanic membrane, or they have evidence of hearing loss and language delay, should be referred to an otolaryngologist. Why is that? Because there is a condition called otitis media with effusion, when you have middle ear fluid without signs of acute infection. So you see, this is a tympanic membrane. It's not red. It's just a bit grayish, but this is called glue. The concept of glue ear. Okay, so this patient had more than 3 months history of persistent otitis media, not resolving, not improving on treatment, and we needed to put a tympanostomy tube for this patient. So that's a grommet tube being inserted into the tympanic membrane. It's a simple procedure for less than 5 minutes. So the indications of tympanostomy tubes, from 6 months to 12 years of age, if you have bilateral OME for 3 months with language difficulties, if you have recurrent acute otitis media. Now that's important. What do we mean by recurrent? 3 in 6 months, 4 in 1 year. Okay, it's recommended to put a tympanostomy tube, and there are many benefits for putting in tympanostomy tubes. Now I'm gonna finish my presentation with epistaxis. It's not uncommon to have an emergency case come to you in the primary healthcare or epistaxis. I just want to point out a few things with the limited instruments you have in the primary healthcare setting. Always start with ABC. It's never wrong to do that. The detailed history and systematic overview might not be clear what the patient is bleeding. Focus on, first of all, controlling the bleeding. So the patient has to be sit up, okay, with chin down. The compression always starts digital pressure over the anterior cartilaginous portion of the nose, not the bony portion, not raising your head to the back, always at the cartilaginous portion. So I know you don't have the headlamp or the nasal speculum. However, examine the oropharynx if you see there is a postnasal bleed. Now, if the patient does not respond after 5 to 10 minutes of digital pressure, we need to think about other things, such as cauterization or packing. Now, there are different types of packing. I know you don't have this, but try with making a ribbon goes into the anterior nasal cavity, at least while you transfer the patient to a secondary hospital. And these are the Mirasols. Okay, other options include, it's a very handy, it's called epistat or balloon tamponade. It's just one way. You just put in the nasal cavity and inflated. Anterior and posterior bleeds can be stopped using the epistat. Okay, let's think about the differential diagnosis, reversible causes, hypertension, hypercoagulation. Okay, I'm just gonna touch on one thing to end up this presentation, okay? The nasal obstruction. There are many, it's a very common presentation. Please don't miss sinister causes. If you have an elderly patient, you have a unilateral, you have an epistaxis that's on and off, it's not always allergic rhinitis or not always anterior bleed, okay? You have a low threshold in referring these patients. Unilateral, always double think. If you have unilateral obstruction, elderly patients, think about things else. And if it's recent or chronic. I'm going to end with allergic rhinitis. It's very common in children in Kuwait due to multiple factors, either the genetics or the pollution factors. It's a type 1 hypersensitivity reaction. You have allergy sensitization, and there are primary and secondary phase reactions. So what are the common symptoms? We have sneezing, clear rhinorrhea, congestion, and nasal pruritus. All right, so we all know the names of these signs. Okay, allergic shiners, salute sign, when you have a crease, supranasal crease from this movement, itching the nose. It's usually associated with reddened eye, arteritis. The patient will be atopic with the eczematous signs. So allergic appearance of a patient should trigger with you the diagnosis of allergic rhinitis. And there are different classifications. We classify them as intermittent and persistent. And if it's intermittent or persistent, it can be mild or moderate to severe. Most common allergens are pollens, animals, cats, insects, and molds. It's very important to take this history if you have any animal pets before starting. And the management should start with nasal irrigations. Many in the market, no evidence of any superiority of any irrigations. We use antihistamines, intranasal corticosteroids. When it comes to decongestants, not more than 5 to 7 days. Decongestions include either the oxymetazoline or Otrivin, what's known. Please do not give it for more than 5 days. And we do have anticholinergics like nasal ipratropium bromide, not available in Kuwait at the moment. And oral, again, we can go with the anti-leukotrienes or antihistamines. So that's what the overview of allergic rhinitis. And I'm very thankful for the organizing committee for the invitation. Inshallah, next time we're going to talk more about other conditions related to the ENT. Thank you so much.
Thank you, Dr. Marwan. So we have a few questions.
Sure.
Is there any sleep studies for children in Kuwait?
Good. We do have pediatric pulmonologists. Very few. We think there are three very good doctors. The issue is they have a long waiting time, okay, to perform the sleep polysomnography. So we need to be very selective in providing our sleep polysomnography. Who needs sleep studies? Okay, patients who, for example, obese, okay, and you're not sure if his adenoid tonsillectomy will provide the relief or not. You just need documentations that what's the stage or the level he's in to perform. Craniofacial anomalies, and if you're suspecting central causes, central neurological causes for CP patients. So be very selective in your referral to the sleep studies for children, for sleep polysomnography. In adults, it's a totally different area. So these conditions that are more complex require sleep studies, not the generalized grade 4 tonsils, adenoids, and you want to do adenoid tonsillectomy for. So yes, that's another good question.
One of the audience asked about the tonsillar stones. What to do at the clinic if we face a tonsillar stone?
Okay. It is not uncommon to see tonsillits, okay, or tonsillar stone. Very controversial. There is no clear-cut or definitive management other than tonsillectomy, okay? But again, tonsillectomy, it can be, especially in adults, a very painful procedure post-op. So we have to be very specific in counseling these patients. We can give local treatments such as oral gargle, okay? I discourage from manual manipulation, not to cause any bleeding or pain, but if in a specialized setting with a camera, with ways of dealing with it, we can be done. But other than the normal antiseptic gargles, not much we can do for it.
We will take one more question. In a case of a child's throat pain, where is it? Yeah. If the center criteria is indicative of a bacterial infection, is it mandatory to do a rapid strep test, or is it acceptable to prescribe antibiotics straight away?
Definitely acceptable to prescribe. Actually, there was no recommendation to perform the rapid strep test in the guidelines.
Thank you, Dr. Marwan.
Thank
Please
you so
accept our trophy of appreciation
Thank you.
from Dr. Dina.
So now let me present our next speaker, Dr. Atlal Lafi, consultant dermatologist, chairman of Dermatology Council Kuwait, chairman of As'ad Al-Hamad Dermatology Department, Sabah Health Region in Kuwait, tutor in Kuwait Board of Dermatology, acting program director of Kuwait Board of Dermatology 2018-2019, tutor in Faculty of Medicine, Kuwait University. Welcome, Dr. Atlal, and thank you for being with us today.
Okay.
And the floor is yours.
Assalamu alaikum. Happy to have all of you in this late afternoon, especially on Friday, and happy to spend my Zwara with all of you. It's my pleasure to be part of the 5th Kuwait Primary Care Conference. I would like to thank especially Chairman of the conference, Dr. Dina Al-Dbeib, for giving me this opportunity. Would like to thank the scientific committee and the organizing committee, and also especially congratulating them for such a brilliant conference. What I saw in this conference is together everyone achieves more. I've seen and was so impressed with the teamwork of each and everyone. So thank you all, each and everyone who was behind such successful conference. So these are my disclosures. I'll be giving a brief overview of herpes viruses and the cause of the disease, the similarities, and the complications, and at the end, I'll give you the updates about the vaccination. So herpes viruses, usually they belong to the DNA viruses, the double-stranded DNA, which is encapsulated by a capsule and also covered by a tegument along with glycoproteins that facilitates its adhesion to the host. The family of herpes viruses include HSV1, 2, HSV3, which is the varicella-zoster virus, and other viruses like Epstein-Barr, cytomegalovirus, and other viruses. I'll be concentrating into HSV1, 2, and 3 in this presentation. So the virus will infect intracellularly and will replicate intracellularly as a primary infection, where we can see it in HSV, herpes simplex virus as chickenpox, and in the varicella zoster and the herpes simplex, sometimes noticed with no symptoms. Then the viruses will be replicating, and they will have a latent period of infection along the neurons, especially in the root ganglia. After many years, there will be, for certain reasons, a reactivation, and this reactivation will give us the secondary or the recurrent infections. So a very quick comparisons between herpes viruses and varicella zoster. The herpes viruses, usually they spread by direct contact, and usually they don't cause any viremia. They are of local infection, and there is no pain, and usually they reside only in the central and especially the trigeminal ganglia. Whereas in the varicella zoster, usually the spread by inhalation and by aerosol, and also it is associated with viremia. Almost all of the conditions also associated with pain, and the spread of the infection, usually it is in a systemic fashion in all neuro axes. So regarding the reactivation, usually the herpes simplex usually reactivates so frequently, and it drops with age. So the older the patient, it will be less. Neurons affected are only few neurons, and usually the pain is not that evident. Whereas in the varicella zoster, the reactivation is very minimal. The reactivation usually manifested as herpes zoster, and it is not that frequent. It is very rare to have repeated herpes zoster infections. The incidence of herpes zoster, the reactivation, usually it increases with age, especially in 50 years and above patients. And the disease usually covering a dermatome. It can also cover more than one dermatome. The pain is the hallmark of herpes zoster, and with the sequelae and complications of post-herpetic neuralgia. So this is herpes simplex, you know, the HSV1, which is causing the orolabial herpes, the HSV2 causing the genital herpes. The primary infection usually happen in a younger age group. And then the triggers of reactivation, usually the UV exposure, the dental procedures, and surgical procedures, especially around the lips. Additionally to the orolabial and the genital areas, it can cause keratoconjunctivitis, which is happening especially with HSV1, and also it can cause encephalitis in immunocompromised patients. They can have also immunocutaneous affection. So this is just showing you the areas where HSV1 more evident, in the gingival stomatitis, in the keratoconjunctivitis, in pneumonitis, and encephalitis, whereas with HSV2, you will see it more with genital lesions and can cause complications of meningitis. So going to an example of gingival stomatitis, the HSV1 infection, usually causing multiple vesicles that soon will rupture, causing ulcerations that is very painful in the oral mucosa. What else they will experience? They will have a foul breathing, they will have dysphagia, and sometimes they experience also a prodrome of the infection. Duration 1 to 2 weeks. Another very common presentation is the commonest presentation is the orolabial herpes, where you can see grouped blisters over the vermilion of the lips. Showing you different examples. This is one of the recurrent reactivation of the herpes. And usually you will notice that it is happening on the same site where it happens previously. Some patients, they will also experience pain, tingling sensation, burning sensation along or preceding the blister formation. Orolabial herpes also can be seen on the forehead, on the cheeks, around the eyes, even in younger patients. It can also have different manifestations with extensive infection, causing a severe oral herpes around the eyes. It can be so severe that may require systemic intervention. Also, another manifestation of herpes is the herpes psychosis, where there is herpes in the hair follicles. Sometimes it is misdiagnosed with fungal infections or bacterial infections. There is another type of herpes, which is called herpes gladiatorum. It was seen in USA athletes because of the direct contact. One of the reasons of spreading is the direct contact. So while wrestling, they were having direct touch to the skin, so manifesting either on the forearm or on the neck. One also of common cases that I think you are seeing it in your clinics is the herpetic whitlow, where you will see a child with one finger having grouped vesicles, very painful, sometimes complicated by lymphangitis and cellulitis. And you may think of seeing the patient that he's sucking his finger, and it will complicate the scenario. Another very dangerous area that you should refer immediately to an ophthalmologist is when it is affecting the eye and causing herpetic keratoconjunctivitis that may lead even to blindness. The herpes genitalis is caused by HSV2. It can cause grouped blisters over the penis, penile shaft, or the vagina. And this is one also of the recurrent infections that needs also prompt treatment. Can we see it in the neonates? Yes, we can see neonatal herpes. Usually 70% of cases are due to HSV2, which is available in the vagina or in the genital area of the pregnant lady. It can be passed also intrauterine. What are the manifestations? Usually they present with skin vesicles, but they can be also complications with CNS manifestation. Atopic dermatitis patients are more prone to colonization with Staph aureus, even if they present with molluscum contagiosum, which is an infection, a viral infection by pox virus. Also, they will have a severe manifestation of molluscum. Additionally, herpes simplex in atopic dermatitis will manifest with a vast distribution, causing something called eczema herpeticum. Although it is mentioned that it is looking threatening, but it's self-limited, what we are doing in Kuwait, we are admitting those cases in the pediatric ward and those cases treated with IV acyclovir to get rid of the herpes. In the immunocompromised patients, usually herpes will manifest so aggressively, so they will have more deep-seated ulcerations, resistant to treatment, very painful, and also they may have a kind of exovatic lesions, vegetative lesions in the presentation. They can have painful ulcers in the tongue, that is manifestation of herpes simplex. How will you diagnose the cases? Usually, we are relying on the clinical presentation, but sometimes clinical presentation is not straightforward, so you will need to do some investigations. We have the Zank smear, which is a very simple procedure where you can see and appreciate the multinucleated giant cells with gem cell stain. And also, what we are doing in our center, we are doing the serological tested, which is very easy, and I think it's available also on the primary care. The PCR, sometimes we do need to do a skin biopsy to aid the diagnosis. Also, there are other investigations like direct fluorescent antibody testing and viral cultures. So now going to varicella zoster virus, the primary infection is the chickenpox, where children usually, they manifest with it. And usually it has a prodromal phase, and then they will have the skin rash, which is the maculopapular skin rash, then developing the teardrop vesicular rash on erythematous base that will soon rupture and doing a crust. Patients may have fever, sore throat. What is more important to appreciate in this infection is infecting adult population and pregnant ladies. They will have more complications, especially pneumonitis and other rare complications like osteomyelitis and keratoconjunctivitis and encephalitis. So immunocompromised patients also, they are prone to have a very aggressive varicella form of infection with a very widespread aggressive infection and also other system involvement, and it can be fatal in immunocompromised patients. So the reactivation of the varicella zoster will be the herpes zoster. The other name is shingles. Usually, it is more evident to be seen in older age group from 50 plus onwards, and also in patients who are immunocompromised, taking immunosuppressive medications, or they are experiencing malignancy, having HIV infection. Also, patients who have family history of herpes zoster, they are more prone to get herpes zoster, and it is thought to be genetically susceptible families. Other thing is the hemodialysis patients and patients who have comorbid conditions, they are more prone to get herpes zoster. So herpes zoster, we mentioned that it is a systemic involvement of all neuro axis in the system. So we can see it in 55% in the thoracic dermatomes, 20% in the cranial region, and 15% in the lumbar region, 5% in the sacral region. This is a classic presentation of herpes zoster, seeing the grooved vesicles or papules or pustules on erythematous base taking a dermatomal fashion. Usually the course of the disease around 1 to 2 weeks, and also herpes zoster can also affect the mucosal part of the dermatomes and can also be a manifestation of the maxillary division or mandibular division of the facial nerve. Can we see it in children? Actually, I've seen only one case of a pediatric age group 4 years old. And yes, it can be seen, but less frequently. Rarely can be seen in pediatric age group because usually they need to acquire the primary infection and then to have the reactivation. It can also end up with scarring. So herpes simplex, herpes zoster can cause scarring post herpes zoster infection. Herpes zoster can be disseminated, especially in immunocompromised patients. The definition of disseminated disease is having more than 20 lesions outside the dermatome, and also there will be a visceral involvement of lungs, CNS in those patients, immunocompromised patients. One of the alarming site of infection is the herpes zoster ophthalmicus, where it is affecting the ophthalmic division of the trigeminal nerve, especially if it's affecting the top of the nose. This is a Hutchinson sign. It is an alarming sign because it is in 76% of patients affecting the eye. So consulting an ophthalmologist is mandatory in those cases. Another syndrome, the Ramsay-Hunt syndrome, where there is vesicles and affection of the external ear canal, and they will have an ipsilateral facial palsy. They will have loss of taste in the 2/3 of the tongue, and also they will have a hearing tinnitus and hearing impairment. Other complications apart from the motor neuropathy, the delayed contralateral hemiparesis, is the post-herpetic neuralgia. So this is an example also of extensive infection in immunocompromised patients taking medications, immunosuppressive medication. Another example of immunosuppressive medication, and patients who are immunocompromised HIV patients, they are 25% prone to have a second episode of herpes zoster. And lesions of herpes zoster in HIV patients, they can be ecthymitis, exophytic lesions, or it can be verrucous lesions. Some patients, we know after the course of herpes zoster and treating the herpes zoster, it is completely resolved. After 1 month or 2 months, patient will come back to you complaining from eczematous lesions at the site of herpes zoster. This is called an isotopic response, and it is thought that this is because of the remnants of the glycoproteins that cause this hypersensitivity reactions. Usually it is a self-limited kind of reaction, but you can use topical steroids in order to get rid of the eczematous lesions. So to diagnose herpes zoster, usually the diagnosis is made clinically, unless you have a doubt because of multiple dermatomes or because of immunosuppressive state of the patient and atypical presentation. So you can go with the investigations that we've mentioned earlier. So I'm not going to go on treatment. You know, the primary infection will differ from the reactivation, and you can also use the suppressive dosage in order to prevent frequent reactivation, especially in herpes simplex type 1 and 2. So before finishing, I'll give you briefly about the vaccination which is available in Kuwait. And this vaccine is called Shingrix, vaccine for herpes zoster, because more than 90% of adults from 50 years and above, usually they are infected with varicella zoster and will have the presentation of shingles. There will be a prodromal phase because they will experience headache, they can have photophobia, and then they will have also the pain, and then they will have the grouped vesicles. It can be vesicles, it can be pustules, papules with erythematous phase, and also main symptom is the accompanying pain. These are different pictures. and followed by a subacute herpetic neuralgia where the pain will stay from 1 to 3 months. And when the patient have the pain beyond this period, beyond 90 days, we'll call it a post-herpetic neuralgia. So post-herpetic neuralgia, one of the commonest complications in shingles. Usually patients who experience post-herpetic neuralgia, 88% of them, they reported that it is a severe kind of pain, and 65% of them, they said it is so severe, and 16% they said it is the worst imaginable pain. So the pain associated with post-herpetic neuralgia is so severe. So what is the correlation between the age and the cellular immunity? Usually it reduces with age, especially after 50 years of age. And the reactivation or the reinfection, usually it is happening to boost the immunity against the virus. We don't have a proper registry in our region, in Kuwait and the Gulf, and this is from other different countries from all over the globe, assessing and seeing the prevalence of post-herpetic neuralgia and herpes zoster in older age groups. So in addition to the older age is other comorbidities that also play a role, especially if patient is diabetic, having impaired renal disease, having autoimmune diseases, he's taking steroids, he can have COPD that will also increases the risk along with HIV and malignancy. So Shingrix takes place in this age group. Shingrix is one of the vaccines that is developed, well-studied as a non-live vaccine. It has particles from the glycoproteins that form the encapsid of the virus, and also with other adjuvant system that formulate the vaccine. So the efficacy of vaccine has been studied in order to prevent the appearance of Shingrix, especially in 2 different age groups. The ZOO50, it was including 50 years and above of patients. ZOO70 included patients 70 years and above. Those patients, they were studied from 18 different countries along the globe. It is a randomized, observer-blind, placebo-controlled study. And in ZOO50, it showed 97 efficacy against shingles in patients 50 years and above, while in ZOO70, it was showing the 91% improvement. And also, they took the 70 plus patients from the ZOO50 and they did a pooled analysis to the group of ZOO70. Those patients has been studied up to 4 years. So the question is this vaccination protecting the patients for a longer period of time? So they did an extended study, which is called the Zoster 049. This study has been conducted and expanded up to 10 years. And it showed that 89% efficacy against shingles and subsequently prevention of post-herpetic neuralgia. So usually patients, especially after COVID-19 vaccination, they are wondering about the side effects of a vaccine. The usual side effects is like other normal vaccinations. There are a little tenderness, pain on the site of the injection, and also other milder systemic presentation like myalgia, having a little fatigability and fever, which usually take 2 to 3 days, and patient will get rid of these symptoms. So how to give the vaccination? It will be a first dose, and the second dose will be 2 to 6 months after that. So it is a 2-dose regimen that will do the needful for such patients. So another question, can we give this vaccine along with other vaccinations? Like if your patient is coming for a flu shot vaccine, would it be possible to give it along with the Shingrix vaccine? Yes, Shingrix can be given and co-administered safely with other vaccinations like the flu vaccine, pneumococcal, diphtheria, tetanus, pertussis. So with this, I end my talk. Thank you, and I'm ready for any question.
Thank you so much, Dr. Atlal, for this excellent informative presentation. We have one question, if you don't mind, regarding the incidence of herpes zoster. Did you notice that it increased after COVID vaccine, especially in teenagers?
Actually, the proper registry of herpes zoster is not well established in Kuwait, but regarding these studies post-COVID vaccine and the incidence of herpes zoster, yes, there are brief publications about the increased incidence of herpes zoster in a younger age group.
Some patients have like herpes simplex, which is truncal and recurrent. And we are referring these patients to dermatologists, and they are on prophylaxis antiviral medication. So from our side, do you have any role in their follow-up, for example, regarding the blood investigation or anything is required from the primary healthcare doctors?
Usually the prophylactic dose, it extends up to 6 months for evaluation. During this time, there is no needed investigations to be done, especially if patient is taking, because the options of antiviral medications are the valacyclovir, famciclovir, which usually we don't have any restrictions in terms of renal affection or liver affection. The exception is with acyclovir, especially in renal impairment. This, we should be aware of that. And as a primary care physicians, especially that you are seeing those patients so frequently, if a patient is missed and is taking acyclovir, I think renal profile should be done in a periodic period of time to assess the renal function.
One more last question. Could we use acyclovir as chemoprophylaxis prevention for a measure for the contacts?
Usually, acyclovir is used for prevention of recurrence in the same patient. But for the direct contact, usually we are not recommending any prophylactic treatment if patient is not experiencing any visible lesions.
Thank you so much, Dr. Atlal.
Thank you.
And now we are inviting Dr. Dina Dbeib, the head of the conference, for a certificate of appreciation for Dr. Atlal. Thank you so much, Dr.
Thank you.
Thank you, our moderators. Please accept our token of appreciation. Dr. Dalal Al-Hajri. Dr. Hassa Al-Ansari.